Good afternoon and welcome to Mood Stabilizers and Bipolar Disorder Discussion. This is week 4 of our lecture, and as we usually do, to start us off, I'm going to go through each diagnosis to make sure that you understand and be able to differentiate between bipolar 1 and bipolar type 2 disorder, and why we use the type of treatments we do and which treatments we also avoid in the process. All right, to start us off, we have bipolar 1 disorder. So by the DSM-5 criteria, it is characterized by there's one or more, mixed episodes or a manic episode, followed by a depressive episode. So we'll get into that a little bit more later, and you guys will learn this throughout the curriculum. But mixed episodes is mimicking symptoms that you can have of both during the same period. But most of the time, to actually diagnose, we must have to have at least one manic episode, and we'll talk about that in just a minute, what that means, followed by, a major depressive episode. There has to be a distinct period of abnormality and persistence of elevation, expansiveness, irritable mood. Sometimes people hear the word mania, and they automatically think, oh, wow, it's great energy, sleeps for the birds. I can go out, I can do anything, racing thoughts. And that is true for a lot of the part. However, people could also exhibit that in irritability, in mood, and aggression. But this has to last at least, this activity, this expansiveness, irritable mood, energy increase lasting at least more than or greater than a week, or any duration of hospitalized. A lot of the times when a bipolar type 1 disorder patient, when they are in a manic episode, that usually warrants for hospitalization, not all the time, majority of the time. The mood also has to, what would be considered for the mood disturbance or increased energy activity, what's the symptoms, how do I know if this is truly a manic episode, So during this time, during the mood disturbance, they're exhibiting inflated self-esteem or grandiosity, decreased need for sleep. You see some patients, I've had patients who say, oh, I haven't slept in 7 days. And it's not that they've been laying there and wanting to get to sleep for a majority of the time. If they're in the midst of a manic, I don't need to. There's so many thoughts. I have to get it out. I have to blog. I have to write. I'm creative. I am recording a song. I have to put out an album. I'm writing a book. Just decreased need for sleep. Pressured speech, it may be very, very talkative, almost you can't feel like you can't even interject during the interview with the patient. Constantly just talking, racing thoughts, flights of ideas. So maybe multiple things, kind of jumping from one topic to another, and just, very, very expansive in their thinking. Easily distracted, obviously more active. You may see patients who are more restless. Physically, it may just be in their mind that has to keep them going, but a lot of times it's harder for them to sit still, hyperactive. Also, excess pleasure or risk-taking behavior. Working and doing residencies at the state hospital, that is the one thing. I remember a patient specifically who had a high-speed cop chase, so this was during her mania. And normally probably would have not known what is, beyond those parameters of what is normal and against the law. But, was even featured on the local news for a high-speed chase with the police. Bipolar type 2 disorder, never actually had a full manic episode, but at least one hypomanic followed by major depressive episode, So when I say hypomania, we're thinking, what does that mean? So it's a lot of the same symptoms. Again, the decreased need for sleep, maybe thinking more thoughts, distracted, lazy, again. When patients describe hypomania, number one, it lasts time, The time length is different. It is usually 3 or 4 days, or maybe less. But usually around there, it's, of course, by the DSM-5 criteria, it says, or 4 days if irritable only, Also, it's more of, as patients describe it, as I finally feel like doing something. I finally feel like getting up and cleaning the house and getting things done and going places and seeing my friends and doing things for the first time in a long time. I had really good energy. I'm getting things more done at work. Things are great. I'm on top of my game. I feel great. And then all of a sudden, there's Mr. or Mrs. Depression back. Okay. So going from this just short little period of, oh, I'm finally feeling better, to deep depression. All right. One thing I want to differentiate. So a lot of times people will say, well, how do you really know bipolar 1 versus bipolar 2? Okay. Number one, again, true mania. Are we even manic as to the point, it was not even in that criteria, but can we elevate to the point of psychotic symptoms, which is possible, okay? Because we've not slept in 7 days, right? We're going constantly, maybe we might be forgetting to eat also along the way. Where hypomania, you may still be eating, maybe sleeping some, but not as much, okay? I don't need to sleep but a couple hours, and I can get throughout my day and I feel great, all right? I'm probably still working and maintaining my job with bipolar type 2. With bipolar type 1, most likely I'm going to have to be hospitalized, okay? So this really out of the norm, expansive elevation during the mania, or really severe anger, aggression, hitting, possible violence, okay, with type 1, type 2. And if you actually talk to patients with bipolar disorder 2, another thing that has been described and taught is that bipolar 2 disorder patients usually are the ones that actually deal with more of the depression, and almost kind of long for the hypomania because they feel good. Not necessarily what that depression is to follow. That's something they dread, okay? And it usually is a fall right back down into depression. But bipolar type 2 usually stay more depressed, okay, with some periods of time with hypomania. Another little clinical tidbit is bipolar 2 disorder actually is the #1 risk factor for suicide. And if you think about that, if you're constantly staying in that depression and you get these little glimpses of finally feeling good, finally, wow, this energy, and I can smile and I'm happy, and then up there it is, okay, right back into the depression. Where type 1 usually does not exhibit chronic depression, okay? There just may be periods. There's some patients who could go 5 years. Hey, maybe they're hospitalized 10 years ago, as long as they're compliant with their medicine. That's another thing too. But the frequency of the relapse, okay, of the flare-up is not quite the same with a bipolar 2 who's consistently dealing with, unfortunately, with depression. All right, so to put them together, just more symptoms, and I really pretty much already described these, but in the DSM-5 criteria, it continues to go on to discuss more of what are these symptoms. Okay, we talked about the mania versus hypomania, but now how do I diagnose a major depressive disorder? What's going on? And you guys, you know, we covered depression, anxiety last week. So if you're going back and remembering what is major depressive disorder, okay, the week before last, then what were those symptoms? And remembering it had to be a 2-week period, okay, with depressed mostly all the time. Remember, maybe they ate or binge eating and eating too much, bearing their feelings, or not eating because they're stressed. They're either very agitated or just staying in the bed, sleeping too much or not enough, feeling worthless, possibly having suicidal thoughts, thinking of a plan to die, and not being able to focus well. Then there's this other thing thrown in there. So we've got bipolar 1, okay, versus bipolar 2. Bipolar 1, more the mania, okay, bipolar 2, more the depression. Cyclothymia is at least a 2-year period where there have been episodes of hypomania and depression, okay, but don't quite meet criteria for a full DSM-5 criteria for diagnoses for hypomania or major depressive. So maybe there was a day or two we're having more energy and feeling good and coming back down, but it's not quite 2 weeks of depression, maybe a few days, okay? It has to be present for at least half the time during the 2-year period, okay? No more than 2 months of no symptoms. That's pretty much, this is a consistent thing for you. No history of diagnoses for manic, hypomania, or depression, okay? Cannot be usually related to a psychotic disorder, and anything I always tell you throughout the DSM criteria cannot be, okay, accounted for. Is this because of a substance, all right? Us doing the high-speed car chase, is that us on cocaine and methamphetamine? Or is this because of our true mania and we do the UDS and we're clear, we're clean, okay? And then, of course, any diagnosis, again, has to have some kind of distress or significant impairment in your social or occupational functioning. So just for you visual guys again, I've got Miss Yvonne here. And so both a little bit to give you of manic, and you may see also some more grandiose makeup and expansive dressing. And then the depressive kind of thrown together, may have not showered in a long while. No sex drive versus also during mania, you may have sex with just anyone, random strangers, things that you would normally quite do. And it's really interesting working with patients. I've seen patients on the manic side and just, I'm looking at this, the vulgar, clanging, rhyming, all these things, grandiose, just, but you know, during that, and I've seen patients be so rude and irritable and just, oh my goodness, during the mania, but when they're good, when they're stable, something they wouldn't normally do. They may have not normally cursed, and then they would curse. So some clinical pearls before we get into the medications and things like that and discuss those more. Historically, bipolar disorders were referred to as manic depression, and you still may hear that as treating manic depression, even some of the commercials for the newer drugs now. Also neurobiological, and I apologize for that, the typing there, the way it centered. Psychiatric disorders characterized by sustained and extreme mood swings from extremely low depression to extremely high. Okay. Both phases adversely affect, obviously, your thoughts, your behaviors, your judgment, relationships. I mean, think about that, though. I mean, obviously, in the mania, that's affected, but also that low depression we talk about in the past as well when we discussed major depressive disorder or unipolar depression, okay? It can affect, you know, that judgment, that behavior. Those relationships, obviously, if you're depressed, you're isolating. If you're manic and you're aggressive, you may be pushing people away. Extreme mood swings that occur hourly or even daily, okay, are rarely associated with bipolar disorder. So I don't know how many times I hear, well, she just went off. Oh, he just went off. Oh, he's yelling. Oh, he's got bipolar disorder or something. Just because you flipped a switch is what I hear most often. And I'm like, you know, you have to step back and talk to the patient and take that moment to educate. Bipolar disorder is not the flip of the switch. Okay, maybe that person has generalized anxiety. And they are emotionally, you know, going through depression, having a breakdown. They're on edge. You know, maybe there's post-traumatic stress going on here. Is there some ADHD and impulsiveness? A lot of times you'll see bipolar disorder and ADHD intertwined and misdiagnosed for each other. You know, really investigate what do they mean by that, okay? Because bipolar disorder is not a quick of the switch. I woke up this morning, I felt great, and now I'm depressed this afternoon. I must have bipolar. Not likely, okay? Mania onset after the age of 40, usually, and not always, and we're going to say more likely, okay, to be caused from medical or substance use. Newly diagnosed, uncommon in adults older than 65. So at that point, we're older than 65, obviously we need to start ruling out, is there some delirium here from something medically? Is there some early Alzheimer's, dementia onset? And then patients rarely present and come into an appointment with the manic phase, okay? They rarely will come to you outpatiently in a manic phase. Now, does that say the never? No, because I've seen it, okay? But a lot of times when that is seeking help, but I feel good. Why do I need to come into the doctor? Why? I'm going to cancel my appointment. I'm feeling great, right? So they rarely present. Unfortunately, it is the law. It's a family member, etc., that's calling, and they're going to need help. So some comorbidities, anxiety disorders, substance use disorder, absolutely. Personality disorders as well. For anxiety disorders, greater than 50% lifetime of a comorbid anxiety disorder with bipolar. Okay, decreased likelihood of, unfortunately, of recovery when there is a comorbidity. Poor role functioning and quality of life, and there are more increased risk of suicide attempts with comorbid anxiety disorders. Substance use disorder, 61% of patients, excuse me, with bipolar 1 and 49% of patients with bipolar 2 also have coexisting substance use disorders, most commonly alcohol use, okay? And if you think about, so alcohol, we're not into substances yet, but it's a central nervous system depressant. So a lot of times you will hear, and you may find a bipolar patient who maybe is not just newly diagnosed, maybe coming in their 40s, but have actually had this for a long time and just not got the treatment, whether it's due to affordability, accessibility, stigma, okay? Finally come in and they've actually been self-medicating with alcohol or with drugs to be able to calm their behaviors, get them to be able to sleep. A lot of times you'll also hear this more and more with marijuana use. Self-medicating, trying to resolve the disorder, okay? Just not ever being, most of the time, not having the proper treatment. Personality disorders, and you guys may get into this more with your therapy course and throughout the curriculum, but cluster B, borderline, narcissistic, antisocial, histrionic, more likely these are more the I guess more in crisis, more against the social norms, more attention type personality disorders, and that can be a comorbidity also with bipolar disorder. So what is the etiology? Like most things in psychiatry, we don't have an exact cause, unfortunately. There are theories, right? So a kindling theory is one of those, okay? Saying that there are multiple factors that potentially interact and lower the threshold in which the mood occurs, okay? There's also, part of that theory is that maybe the mood episode started on itself, and because you've had it once, it can now become recurrent, all right? Also, part of that same kindling theory is that maybe there's some endogenous compensatory mechanisms leading to cell apoptosis, so then in turn causes rewiring of the brain, then involved in mood regulation and cognition. So then we're having some kind of issues, okay, due to cellular death, okay, or rewiring of the brain, all right. And then maybe it is that we're just more vulnerable to the effects from stressors, okay, and because the effect of stress on our body, then we're more predisposed for those mood dysregulations. Other theories, environmental. Sleep deprivation, maybe not getting enough sleep or oversleeping, maybe, and oh gosh, I see this a lot, traumatic and abusive histories in childhood. My gracious. I see that very, very often. Also biological, genetics, okay, and we're going to see this, you'll see this again when we cover psychosis and psychotic disorders next week, but studies show identical twins are far more concordant with mood disorders than fraternal twins. And that is the same thing with schizophrenia. 4 to 24% of first-degree relatives of individuals with bipolar 1 are also diagnosed with bipolar 1. So again, does mama, daddy, anybody in the family gathering that good social history? Is there a history of bipolar disorder in the family? Other etiologies, again, there's a belief of hypersensitivity of melatonin receptors, that there are abnormalities in the amygdala, the hippocampus, prefrontal cortex, that there is also the belief of, hey, our norepinephrine and our serotonin are a little bit out of whack, right? And maybe we have too much serotonin going on during a manic episode. There's also, there's a white matter belief that there are hyperintensities if we were to look at a scan. And then maybe also with thyroids. So let me say this too. I have seen before, and that is a teaching that someone in hyperthyroidism, if you think about it, hyperthyroidism, okay? So maybe they may have more energy, more alertness, lacking of sleep, constantly be thinking more, they're more on edge, okay? So it can mimic mania. Also hypothyroidism, right? Mimicking depression. So there is some belief there is also looking at our endocrine. So psychopharmacology, talking about and how do we treat bipolar disorder, okay? So treatment of patients with mood disorders should, obviously we need to look at what is our goal. First, we've got to look at the patient's safety. Second, we've got to complete that diagnostic evaluation. Is this truly bipolar disorder? Is this ADHD? Is this post-traumatic stress? Is this generalized anxiety? What's really going on here? Okay. And then pending upon that diagnosis, create that treatment plan. And then also taking into account their well-being, what is best for them, what are they looking for, what are their goals in their treatment, okay, what needs to be initiated. Mood stabilizers are the, first line treatment for bipolar disorder. And that is actually what we're going to focus on for this lecture specifically. Yes, do we use second generation antipsychotics? And we use, even some of the older typical antipsychotics, things like that. However, we're going to go over those next week. We're going to focus on just mood stabilizers today. All right, so let's start with an oldie but a goodie, okay? Everyone at some point or another has heard of lithium. Unfortunately, it sometimes gets a bad rep just because people thinking, oh my gosh, this is a ion version on the periodic table of a lithium battery. This is a salt version. What is lithium? Okay, people may have more of an uneducated opinion. It could be because they've heard there has to be lab work, okay, or just because they associate bipolar disorder with lithium. All right, but lithium, guys, is ultimately hands down still the kind of the gold standard treatment, okay, for bipolar disorder. And we'll talk about it here in just a second. Also used, and it can be helpful for major depressive or treatment-resistant major depression, okay. So FDA approved for manic episodes, maintenance treatment of manic depression, okay. Off-labelly bipolar depression, or in other words, what, guys? Bipolar type 2, okay. Major depressive disorder, so I was just mentioning, adjunct, okay, not in by itself, there's not as much research there, but with an antidepressant. On the horizon, lithium. Lithium is showing that there is some neuroprotective factors there when it comes to dementia and memory, that and even Depakote. So, there is a question out there is, do we all need to be on a little lithium? Obviously, there's still more research going. But at the present and current, what we know from research, 25 milligrams per day of lithium can be considered for at-risk persons, okay? If you have a genetic history of dementia, middle-aged, older persons, if there's been other things that have gone on, maybe there was brain damage, and you're more predisposed to these things, then possibly a low dose of lithium can be beneficial. You're going to notice for 3 of these mood stabilizers, I'm going to put, and there is a level, okay? I went with your Kaplan and Sodix text of your therapeutic level for you guys to know for study purposes, but 0.5 to 1.5 milliequivalents per liter. I learned personally 0.6 to 1.2. We're going to go by what text that you have, okay? That varies a little bit, and even when you draw labs, if you'll notice your lab parameters, depending on which company and if it's LabCorp or the hospital, whatever it is, you'll see a little bit of variance there as well. But most of the time, the main important thing is to get right around that range, and you'll learn really for treatment most of the time, if we're targeting and we're looking at those, what we can push is we're maintaining around 0.8 to 1, whereas your textbook actually says 1 to 1.2, okay? Make sure you know your levels. All right, so how does lithium work, or what is it supposed to do for a person, okay? So rapidly absorbed by oral administration, all right? Peaks within 1 to 1.5 hours for standard preparations and 4 to 5 with controlled release. There is a lithium short-acting version, immediate release or IR. There is also a long-acting ER that a lot of times can actually be given even once a day, but there is a general belief in a majority that possibly could be easier on, which follows me to the next thing, easier on the kidneys. Lithium is excreted by the kidneys. Okay. A lot of times, I'm going to start right there for a second to say, a lot of times while lithium is still people's last resort, or maybe not the first go-to nowadays, is because of watching the kidneys, the damage to kidneys. Someone told me a long time ago, when you start lithium, think about 30 years on the kidneys. You've got about 30 years on the kidneys. And so for that particular psychiatrist, she never went with lithium. Usually for a younger person, she waited until it was absolutely necessary and she'd gone through her trials, or when they had a little bit older and had been through more episodes. Now, if we look at what she said, though, if we look, further pick that apart, there's also research saying the more episodes, the more relapses you have, the more damage to the brain, okay? So your outcomes are more poor. So it's really going to be patient specific, okay? But lithium is excreted by the kidneys, and one of the things we have to watch. Half-life is 18 to 24 hours in young adults, shorter obviously in kiddos because of their increased metabolism, and longer in older adults as their metabolism slows down. Equilibrium, or getting that good maintenance, stability effect, right, within 5 to 7 days, okay? And this is something a psychiatrist taught me a long time ago as well, is usually when I was working inpatient, when I started lithium, within 5 days, I'm going to go ahead and order my complete blood count, my complete metabolic panel, and a lithium level, because what I'm going to look at is that lithium level within 5 days of that draw should be therapeutic enough so I can figure out, can I increase the dose again, okay? So equilibrium usually reached within 5 to 7 days. Excretion does, which is interesting to me in reading this, but there is some correlation with excretion increasing in those who are obese and also during pregnancy. But, of course, after delivery, and maybe it's because also there's some weight loss there, then excretion actually can decrease, okay? So we may have to look at dosing at that point. And so you're aware lithium is excreted in the breast milk. Lithium therapeutic indications. So what is lithium for? Well, we know bipolar disorder, but what does it do? Okay. Well, for manic episodes, all right, it can help control acute mania and relapse in 80% of people with bipolar I disorder. That's an extremely high number, and that's obviously showing why it still stands to be the gold standard treatment. Relatively slow onset of action for anti-manic episodes can be over 1 to 3 weeks to really kind of augment and bring down those mania. But during that time, that's why usually there is a benzo, antipsychotics on board, possibly even Depakote, usually for the first few weeks as lithium is beginning titrated to be stable and to be therapeutic. For bipolar depression, shown to reduce the incidence of suicide with bipolar 6 or 7-fold. Can be augmented with Depakote or Tegretol with little risk of precipitation of mania. And when depression occurs, okay, or let me say this, when depression occurs while a patient's taking maintenance lithium. So we've been on a dose for a long while, they've been doing so good, all of a sudden we have some depression and things coming back. We need to rule out differential diagnoses. Again, is there something medically going on? Is there a urinary tract infection? Has there been something happen in their life recently, something traumatic that has changed? What about medically? Has their medical medications changed, any substances? So rule out those things. And then if not, and you're looking at the dosing, and if our labs have been pretty stable, maybe we're at a 1 already and we don't want to risk toxicity, which we'll discuss in a second, then we have the option to maybe add lethiorone or cytomel, which is just a thyroid hormone that we can add as low as 25 micrograms per day to see if maybe we can augment that. And that was actually, cytomel has indications for safety. Even if you have normal thyroid panel, a little cytomel can be added. I just have personally, I have one patient who's on that I actually didn't start, but have maintained, and I think we're on like 12.5 micrograms a day. But for her, it makes all the difference in the world. All right, also indicated for major depressive disorder, okay? Effective in long-term treatment as an adjunct, as I said earlier. Smaller doses can be added for effectiveness. So the lithium dosing for major depressive versus lithium dosing for bipolar, we're going to talk about dosing here in a minute, is a lot smaller, okay? You don't have to follow just the piece of paper and be like, oh, well, your lithium level is 0.3 and it's not therapeutic, so therefore I need to increase it. If your patient is doing well, they're happy, they feel great, they're sleeping, they're eating, they're functioning at work, irritability is down, just making a difference for them, it does not matter what a piece of paper says, okay? In that regards, if you are under what is considered therapeutic on a piece of paper, go by your patient, okay? And think, you're not treating bipolar. If you're using it as an adjunct with antidepressant, smaller doses are okay. Schizoaffective and schizophrenia. Persons with predominantly mood issues with schizoaffective are more likely to respond to lithium than those who are predominantly more psychotic, maybe not as much, but that makes sense, right? It's not targeting the psychoses, it's actually targeting the mood, okay? And to throw in there too, to make sure if you didn't understand for the pharmacological action, again, it is theory, guys. There is not hardcore research saying we know exactly how lithium works, but we think that it may decrease our norepinephrine and serotonin and level out more of our other, and possibly our dopamine, leveling those neurotransmitters and helping with our mood and so forth. But again, no absolute no of action. So in this case, it's not going to really do anything for the psychosis, but it is going to help with the mood. So other things that it can be used for, we actually use it in obsessive compulsive disorder, ADHD, eating disorders, phobias, aggression, premenstrual dysphoric disorder, and even we already talked about the cognitive disorders. So drug interactions with lithium, and I just picked a few. If you actually want to look at more, you can refer to your Kaplan and Sodic text, and there's actually a table in your chapter. Your table chapter should be 29.19-6. There should be some drug interactions there, if I wrote that correctly on my notes. But it is in your Kaplan and Sodics. There is a table there for you to review. And so let's pull the couple, and I pulled the more common, actually the ones that more stand out to actually have issues with, okay? So NSAIDs, my gracious, people who may have chronic pain or migraines and consistently taking Excedrin, ibuprofen, etc., if they are chronically or if they have arthritis and taking an NSAID every day, okay, it may reduce lithium clearance. Therefore, okay, I'm not clearing it. I'm not getting rid of it as I should, so I'm keeping it in my body longer. I'm at risk for increased serum concentrations, possibly toxicity, okay? So let me say that again. NSAIDs can reduce the clearance, may increase serum concentrations, okay? Now, is that someone who just randomly takes an ibuprofen every now and then? No, okay, not as much, not a concern as much. Those who, again, generally are taking or staying on NSAIDs for chronic pain issues, what have you, please make sure that you address that with them, okay? Or if you know they're going to be on NSAIDs, you may have to lower the dose of lithium, knowing, okay, that we're not going to excrete it as we should. So, thiazide diuretics, again, same thing here. ACE inhibitors, all right, same thing. Reduces, okay, so NSAIDs, thiazide diuretics, and ACE inhibitors all reduce lithium clearance, therefore increasing concentrations of lithium in the body, okay, possibly toxicity. Does that mean you cannot be on an NSAID or a diuretic, a thiazide diuretic or an ACE inhibitor at the same time? No, okay, we just have to have that information for our dosing purposes, all right, and keep an eye on those labs. Metronidazole, again, you take a one-time flagyl. Am I worried about it? No, okay. However, if you had labs scheduled the very next morning or a couple within, a certain period of time, possibility, yeah, it may not be, your levels may not come back completely accurate. And it's good to have that information if they've recently had a yeast infection or anything else they would have had to take in that for, okay? All right, more adverse effects for lithium. Neurological, there can be a tremor, okay, slowed reaction time, memory difficulties. If it were to progress in toxicity, you can have ataxia, a harder, more coarse, visible tremor, okay, neuromuscular irritabilities, even seizures, coma, and death. And we'll talk about toxicity here in a moment, okay. Endocrine can have hypothyroidism is more common, okay, let me say that. So hypothyroidism is more common with lithium. So another thing to go ahead and add on the board there that we're checking with labs, we're going to go over how often in a second, is add you a thyroid profile, okay, or a TSH. Cardiac, very benign T-wave changes. We don't necessarily worry about cardiac as much, okay, as we do renal, which should be the next one. Morphologic changes, polyuria, and even reduced GFR. All right, a reduced glomerular filtration rate. So we need to keep an eye, again, on those kidneys, right? Because kidneys are flushing out toxins, things like that. And if we're slowing those things down, if we're changing it, we need to keep an eye. Dermatological, acne, hair loss, psoriasis, rash. I will say that I very, very rarely, if any, have actually specifically seen those with patients, but that doesn't mean it doesn't happen. GI, nausea, vomiting, diarrhea, appetite loss. Nausea maybe again in the beginning as patients are getting used to it. Normally that subsides. Same thing for the diarrhea, upset tummy. It usually subsides. If not, something to definitely look into. Other possible side effects, weight gain and fluid retention. I've seen these some, not as often as compared to other drugs. A lot of times, sometimes lithium is actually my choice, trying to get around the atypical antipsychotics and weight gain. Signs and symptoms of lithium toxicity. All right. So if we're above 1.5 to 2, now we can have some vomiting, some stronger, hurtful abdominal pain. Again, maybe we're seeing this ataxia, so a little bit of hand shaking, dizziness. Our speech isn't quite right, nystagmus, our eyes aren't focusing correctly. Our eyes are kind of twitching, and muscle weakness. Moderate to severe, so now we're creeping over 2. Now we don't feel like eating at all. Persistently nausea, vomiting, okay, blurred vision. We have, and that should say hyperactive deep tendon reflexes. Possibly go into seizures, delirium, coma, or stupor. If we're above 2.5, again, seizures, oliguria, now your kidneys have said, that's it, I'm done. Kidneys are failing, quit producing urine, and possibly death. Now I want to share while I'm on this slide, again doing residency at the state hospital, there was a client who, her provider started a very high dose regimen of lithium. Okay, we're going to get to dosing here in a minute. But unfortunately was a lot of times mistaken per race. Okay, as to more commonly or not, more African Americans are often misdiagnosed or mislooked at, stereotyped to need more dosing when in reality actually need a lower dosing, okay, and metabolized differently. Was put on high doses of about 900 milligrams 3 times a day. Very, very, very high dose. Now, did that patient seem to calm down a little bit? Yes. The only reason we're aware of this case is because my preceptor at the time, the clinic director actually, or the clinical director of the hospital, actually was covering while the primary psychiatrist was on vacation. The nurses had reported the patient was barely even responding, kind of slumped in her chair, very lethargic, seemed very weak, was slurring her words, just they couldn't hardly even arouse her. So immediately, hey, we need to draw, looking at meds, seeing that dose, we don't even see a lithium level. When was a lithium level drawn, y'all? Okay. Please, please make sure you're drawing a lithium level when you start a medication. Please. Okay. We could not find it anywhere in the chart. Drew the lithium lab. Okay. Lithium level. Came back 3.2. All right. 3.2. So if you look at this, we're beyond severe. Okay. We're in that severe, right? This patient should not be in a state hospital without the medical equipment, medical intervention, and things that we need. So immediately patient was transmitted over to the local medical facility, actually was put on dialysis, given fluids, dialysis, trying to lower the system, and she did make it, okay? But I share that story because lithium can be an amazing drug. But please, 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 even if you are working right now as a registered nurse on the floor and you see a patient on lithium, even if they're from a med-surg floor, okay, please remember to look, when is the last time a level was drawn? Do we have those records from that current prescriber? Do we need to draw them at the hospital and check on things, okay? Just, if you're going to start it, and every time you change or titrate a dose of lithium, okay, you need to be checking that level. All right, so as I mentioned, for that particular patient, her management was sent straight to the hospital for dialysis. By your SODIC, Kaplan and SODIC, it says that greater than 4 receives the dialysis. I think it's that, and that everybody's a little bit, their practice discretion's a little bit differently, and that's what they saw fit for her. So the first thing you need to, if the patient is exhibiting symptoms of toxicity, they need to either go to the ER, obviously, contact the doctor, let them know, go straight to the ER. Stop the medication. Vital signs, neurological exam, you need to draw those levels, electrolytes, check on the kidneys, get an EKG. Okay, we may have, you may have to do a gastric lavage, you may have to do activated charcoal, depending on what the level is. Okay, and how fast we need to get that level done, like I said, in severe, into dialysis and fluids. So here's where I talked about the dosing. Remember, okay, I'm telling you that patient what that dose was, okay? So for acute mania, normally we start at 300 milligrams 2 to 3 times a day, then titrated upward as indicated by the plasma levels. This is us getting those levels back, okay? Kind of saying, we're not stable. He's not sleeping, okay? Still wanted to hit the nurse the other day. Still cursing people out. Okay, you're having to use that objective data as well as talking with your patients, getting that subjective. Are we stable? If not, maybe we're only at a 0.6. We have some room to grow. Okay, for long-term treatment of mania, adults and children 7 or older weighing more than 30 kilograms, 300 to 600 milligrams, usually 2 to 3 times a day, is our normal maintenance dose. Okay, just lithium is not recommended right now for children under the age of 7. If we're going to be extended release tablets, as I told you, immediate release above, for long-term treatment for adults and children 12 or older, okay, they haven't approved yet for the long-acting on kiddos under 12, usually 600 milligrams twice a day, or up to 300 times a day. So again, when we look at this dosing and what that female was on, very, 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 very high, beyond the norm. Monitoring of lithium, what are things we need? I already has mentioned the tests. We've already talked about watching the kidneys. But before we even start, okay, go ahead, especially if they're over the age of 50, let's get a baseline kidney function, TSH, EKG, and those are things actually like, well, what do I do if they're already in there? Like, I need to go ahead and start them on treatment, but you need to be going ahead and getting those labs the same day too. If you have that capability where you have lab to be able to draw in the same office at the same day so that you get that back relatively quickly if you need to talk with the patient or get them to hold off on treatment. If you don't have that capability, then you may have to hold off until you, again, but it's going to depend on the patient's symptoms. If they're acute enough and need something quick enough, we may have to start them and wait on those exams, okay? So monitoring kidney function, usually once you're stable, okay? Once we're not changing the dose, all right, 1 to 2 times per year. And usually it's about every 6 months we're getting their level. It's not like they're going to have blood drawn all the time, especially for those without insurance. That can be costly. So something to keep in mind and for education for your patients. We do need to monitor for metabolic syndrome. Make sure we're just keeping an eye on their weight and their lipids and hemoglobin A1C. Those can be, again, those can most likely be drawn about once a year. And a lot of times they're actually already being drawn by primary care. And so we can receive copies of those to prevent the patient from having to repeat the exams or spend more money. So teaching patients when you're going to get your lab work, it needs to be about 12 hours. So your last dose of lithium approximately 12 hours before the last lab draw. Okay, so usually you've taken it that night. That morning, if you are on a twice a dose regimen, you're going to hold your morning dose. You're going to get labs. After labs are drawn, then you can take your medication and resume, go get you something to eat, whatever it is, okay? Avoid a sudden change in diet or fluid. And this kind of goes along with the next one. Caffeine and alcohol can act as diuretics and can lower serum concentrations. Okay, that's part of your diet, right? So if you've chronically been drinking, you've been a drinker, and all of a sudden you stop drinking, well, you may have more of a risk that you're going to have increases in your serum concentrations because all of a sudden you've had something that's been lowering it and excreting fluid, and now you're going to be retaining it, okay? So we've got to keep an eye on that. Also, those who maybe want to lose weight, and hey, I've got high blood pressure issues, I'm going to watch my sodium intake, and I'm going to all of a sudden just stop. But whoa. Okay, if you restrict your salt, lithium is, it's like your body tries to conserve the sodium it has, and lithium being a version of a salt, it will try to save it. So when you cut on your sodium suddenly, your body's going to hold on to lithium being more toxic. Or maybe, oh, I need to drink more fluid, I'm trying to lose weight, I'm going to drink lots of water, and my goal is a gallon a day. If you've not been normally drinking a gallon a day, okay, then we're just flushing it out, and our lithium levels may become under therapeutic and then not working as good for you, and maybe that's going to precipitate a manic or depressive episode. Changes in exercise as well. If we think about the more you sweat, then we're losing some of those. Again, can affect our lithium levels. So any just sudden change from the normal, what you normally would do, does that mean you can't walk and go jogging and join aerobics and Zumba or any of those? No. Does it mean that you can't all of a sudden want to increase your water? No. Just keep your provider, teach patients to keep us informed, okay? So we are aware and we can watch those for those dosings. All right, moving on to Depakote. So valproic acid or Depakote, here's another level, okay? Remember, get to know your levels, 50 to 100 millimoles per liter, okay? So valproic acid, as you may see it, or Depakote, okay, FDA approved for acute mania mixed episodes. All right, there is a delayed release version. There's an extended release. I will give you just heads up for a pricing point. The delayed release version is actually cheaper. Sometimes the ER can be relatively expensive for patients. And there is a plain. There's actually a Depakote sprinkles that a lot of times you can open the capsules, mix them with applesauce, ice cream, etc. for elderly individuals and children. So off-label, we also use Depakote for the maintenance of bipolar disorder, bipolar depression, schizophrenia or psychosis adjunctively to their antipsychotics, and again with dementia. So what are its actions for Depakote? Well, biochemical basis, again, misunderstood, or we don't know. There's still, again, no 100% of knowing exactly how. Theory, possible mechanism with the GABA activity, modulation of sodium channels or action on the extrahypothalamic neuropeptides. Can be readily absorbed within 1 to 2 hours after administration with a peak 4 to 5 hours after oral administration. Okay, something to know, keep in there. Okay, usually that is with your immediate release. Plasma half-life, 10 to 16 hours. All right, one thing I didn't see specifically is that your Kaplan acidic to go on to talk about when it reaches its peak or its stability, its therapeutic level. So with Depakote, again, food for thought or clinical tidbits. In the inpatient unit, it was about 3 days. We kept a patient, which if you do the rule of fives, half-life times 5, okay, and then we're looking anywhere in that range. So anywhere around 3 to 4 days, but at 3-day marker, we could actually redraw our Depakote level, and at that point, make a decision, can we go ahead and increase again? Now this is if we're inpatient, we're moving relatively quick. When I told you the lithium, and at 5 days after, we can redraw the lithium level as well. Okay, that does not mean it's what we're going to do in outpatient. That is more of an inpatient setting, moving relatively more fast. But in an outpatient setting, usually you start something within a week. You're going to check back and get them back to get labs in a week and come back and see you in a couple. However, again, depending on the case. Okay, how severe is this patient? All right. But so we last said plasma half-life is 10 to 16 hours, highly protein bound. The extended release option does produce a lower peak concentration but higher minimum concentration, so it can be given once a day. And I'm just going to tell you guys, more often than not, it is normally at bedtime. Okay, a lot of patients will have sedation, as we'll talk about here in a second, with adverse effects, and they tolerate it best at bed. So more on the indications, just to give you a little bit more detail with these therapeutic indications of Depakote. For the acute mania, 2/3 of persons with acute mania will respond within 1 to 4 days of achieving a serum concentration of at least 50. Gradual dosing may achieve serum concentrations within a week. Okay, this is where I was saying, okay, within a week, most, but within 3 days, just as your clinical tidbit that you can actually check again. Rapid loading, and here we are too. Rapid loading achieves serum concentrations usually within a day and control symptoms within 5, okay? And can be augmented with, and that should say with, Tegretol and antipsychotics. I am on the roll today with spell check. Acute bipolar depression also can be more effective in the treatment of agitation than dysphoria. Okay, so let me say that again. For bipolar depression, for Depakote, for this thinker type 2, more effective in the agitation than usually the dysphoria. Does not mean it cannot help the depression, okay? And might be a darn good choice for anxiety, okay? What is the more problem thing that we're having along with this, okay? But usually with bipolar depression, type 2 bipolar disorder patients, usually an adjunct with an antidepressant. Schizoaffective / schizophrenia can actually help accelerate the response of antipsychotic therapy. It's more of just decreasing that agitation, calming them down, maybe the impulsivity, maybe it's the just stabilizing the mood so that some of the psychosis actually gets better. However, that'll be a differentiating factor when we cover psychosis disorder. A lot of times, even in I'll just go ahead and say it, even with schizoaffective disorder, how we decipher versus bipolar disorder, okay, is once you've treated the mood, usually the psychosis disappears if it's truly bipolar. If it's schizoaffective, you may still have some underlying psychosis that remains after treating the mood. Ineffective, used alone for psychotic symptoms. Other things we can use Depakote for, alcohol withdrawal, relapse prevention can be great to help with the cravings. Panic disorder, post-traumatic stress, impulse control, certain personality disorders, behavioral agitations, and dementia. Adverse effects of Depakote common, GI irritation, nausea, and I'll tell you guys, nausea is probably, it's the most common thing that you will hear is being a little upset, and the best thing we can tell our patients is, get a little ginger ale, if you have to use a temporary dose of Zofran or something to assist with it, to help him with the nausea. Can make you sleepy, as I mentioned, possible tremor, weight gain. Unfortunately, Depakote can be an amazing drug, but so many patients I have seen, one of our issues is the weight gain. But this can be a great, go ahead and get them loaded, get them stabilized, and then we can look at some of our other mood stabilizers that might be a little bit more slow going to start along with the Depakote. Hair loss, that's something actually is possible as well. And one thing that you can tell your patients is actually get some zinc, and that can also help with the hair loss caused from the Depakote. And one thing that wasn't mentioned in your text is it actually can decrease your calcium, vitamin D levels, cause more risk for osteoporosis. So also educating your patients to go ahead, if they're going to be on Depakote, if it's going to be a long-term thing, that they also need to be taking some calcium, vitamin D would be beneficial. Uncommon is the vomiting and diarrhea, having ataxia, persistent hepatic, elevated liver enzymes. Okay, so that is interesting. Sometimes you can draw a lab and you're checking after you start and you're like, oh my goodness, oh no, I've elevated, their ALT and AST is elevated. Depakote's not my answer. Hang in there, okay? Sometimes if you'll redraw it and you give it time and not freak out, redraw it and those will level out. So that is common that you will see intermittent, sometimes increased liver enzymes, okay? Do not freak out unless you've consistently gotten a couple and they're still elevated or they continue to elevate and get worse. That is a concern, okay? We may have to stop that medication at that point. So I mentioned lithium in kidneys. Kidneys, lithium, okay? Depakote goes along with liver. Watching liver with Depakote, all right? More rare adverse effect, you can have some platelet dysfunction. I have seen that, or actually it's more the granulocytosis, the next thing. With one patient, we're actually able to reduce her dose, and we've stayed well. Looking at, and that's one of the things, again, do not freak out by looking at, oh my goodness, I've dropped their white blood cells. Wait a minute. Is this a common trend? What is prior to the medication? How were we running? Were they automatically already low? Do they have a history of issues or different types of cancers that may have decreased that, okay? Get the whole picture before you suddenly rip away the medication. And then lastly, more rare, and I don't quite normally see this, but with edema. So dosing for bipolar Usually for mania is anywhere from 12 to 1,500 milligrams per day. Okay. How to dose, usually starting for mania at 15 mg per kg and 2 divided doses or once daily for ER dosing. Acute mania in adults, initially you can load with 1,000 milligrams per day and then increase, okay, depending again on that labs and tolerating, but usually at 60 mg per kg per day if we are front loading for someone who's in an acute severe mania, okay? If we're less acute, maybe we're outpatient, 250 to 500 milligrams on the first day and then titrating upwards as tolerated. A lot of times you will see someone start 250 the first night and then go to twice a day thereafter, or depending on the patient, again, I'm seeing 500 milligrams initially, then twice a day thereafter, okay? Until you know, is there side effects? Are they tolerating it? If so, we might be able to change over to the ER. So Depakote monitoring, we already mentioned, think liver, okay? So prior to starting, especially if it's not someone who has generally had maybe a history of multiple health conditions, medical issues, so forth, you want to at least get a baseline liver function. You want to get a complete blood count with platelets and a pregnancy test. Depakote can have some tetragenic effects, and the baby we'll get to talk more about when we get to pregnancy and lactation chapter. It is not one that we choose usually with pregnancy, so we need to make sure that they're not pregnant. Reoccurrent, also liver function test. That means so that we've decided to stay on the medication, we're doing great, keeps well, great. Then every 6 months to once a year, we're going to check our liver functions again, a VPA level, our valproic acid, and are usually a CBC. So it's usually a CBC, CMP, and a VPA level, okay? Now, again, that does say 1 to 2 times per year thereafter, meaning the first few months are when you're getting stabilized, titrating, changing the doses. Obviously, we're checking it more often, okay? Plasma drug levels. You also want to make sure that you're just looking. I mean, if you're low, you know, is this low because we've been stable, or they're complaining to you, they've got all these things going wrong. You walk into your office, they apparently seem manic, and you draw levels and you're saying, we're at 30. You know, investigate more. Is there some compliance? Is there a new medication on board? And is there anything that may be suppressing or changing it? And monitor metabolic syndrome. Depakote is, and a lot of times too, not necessarily recommended with people with polycystic ovarian syndrome, because already the increased risk of insulin issues with insulin resistance and weight gain issues. It's not one that usually we'll use for those patients because of the more likely to precipitate those symptoms. All right, lamotrigine or Lamictal. So FDA approved for the maintenance of bipolar 1, off-label bipolar depression, aka bipolar type 2, right? Bipolar mania is usually with adjunct or a second line because it is not going to be as quick of a loader, and you're going to see here in a moment. Also used for neuropathic pain or / chronic pain and major depressive disorder as an adjunct, okay? All right, actions. Completely absorbed. Steady state of plasma life is usually in 25 hours. The rate of metabolism depends on which drugs are co-administered. So what that tells me is that there can be certain medications that can make that metabolism speed up or decrease, okay? Dosing is usually escalated slowly to twice-a-day dosing according to your Kaplan and SADC. However, a lot of patients usually will just do it at bedtime, depending on the patient, though, and what are we using it for? Are we using it for anxiety? Are we using it for mood stabilization? How are we using the Lamictal? Food does not affect absorption, so that's a great thing. You take with or without food. There is some belief that it modestly increases serum serotonin concentrations, therefore possibly through the inhibition of serotonin reuptake, aka stabilize mood from below. Lamictal has been more, you see more benefit with the help with depression than you necessarily do with actually kind of decreasing the mania, okay, or aggression can be, but it's a lot of times you'll see that associated more with helping with the depression part of things. Adverse effects, possible dizziness, ataxia again, somnolence, that's why I say it's usually once daily dosing at bedtime more times than not. Possible headache, blurred vision, nausea, there it is again. Again, if you're taking these things at bedtime, you're less likely to experience the headache, the nausea, so forth. I've got asterisks right here with rash. So commonly and occasionally, very severe, okay? So if you were to have a rash, if you were to ignore it, as I tell my patients, it is not just your just common rash that maybe you had a heat rash or you got into something that irritated you or were more sensitive to, but that it actually was more of a blistering rash, more of a rash that was more worrisome or kind of, not the correct description, but funky looking rash, okay? That is when they need to do not take another one. They need to pick up the phone, they need to call you, they need to let you know, describe the rash, find out when it occurred, was it there prior to administration, how long have they been on medication, what dose are we looking at, do they need to come in so we can look at it. If we think this is lamictal rash, they need to stop. And more likely than not, most of us are actually going to stop the medication for safety reasons just in case, because if you were to leave it and just ignore the rash, and it will just keep spreading. Like, oh, look at that one. Oh, it started on my arm. Oh, now it's on my face. Oh gosh, there's another on my leg. If you let it to continue to spread like that, it could develop into or manifest into Steven Johnson, so your whole body can turn into that and be potentially fatal. Okay, so need to be aware of that. Now I'm adding this on there because concurrent use of Depakote with Lamictal can double Lamictal serum concentrations. Therefore, okay, when we're doing Lamictal, and you'll see in a minute when we talk about dosing, if I'm going to maybe my patient was having weight gain with Depakote and I would like to start Lamictal and get them over to it, not a bad choice. However, okay, be aware Depakote can increase the Lamictal concentrations. So therefore, all right, I may be more at risk to have this rash, all right, and I may have to move even slower with the dosing regimen to prevent the rash from occurring. So here we are with dosing. All right, usual dosing for Lamictal is usually up to 200 milligrams per day, up to 100 milligrams per day in combination with Depakote. Again, that is pending a pump. That is usually your max if they're still with Depakote. If you're ready to move to 200, then you're probably going to be stopping the Depakote at that point. Up to 400 milligrams per day if you're also on an inducing anti-epileptic medication such as carbamazepine, which is Tegretol, phenobarbital, or phenytonin, Dilantin. Okay. If you're on something like that that is actually causing you to excrete it more quickly, then you may need higher doses to maintain in your system. So for the normal, typical person who's not on Depakote, they're not on any other anti-epileptic drugs, okay? You usually start 25 milligrams, one tablet once daily for 2 weeks, then go up to 50 milligrams once a day for 2 weeks, and thereafter, it's usually 100 milligrams once daily thereafter, okay, for targeting mood stabilization. Depending on, again, what you're using it for, there have been Lamictal dosings as twice a day, as small as 25 to 50 milligrams twice daily, used more for anxiety, okay? Or we're using this just more for adult depression, bipolar disorder, that might be a once daily dosing. And then usually you can go up from the 100 milligrams, at least 2 weeks minimum on the 100. A lot of cases it's usually 4 weeks to go up again to the 200 milligrams. If they're on Depakote, this is where it gets a little icky. You have to start even slower. So it's 25 micrograms of Lamictal once every other day for 2 weeks, then every day for 2 weeks. Then you can finally get to that 50 milligrams per day for 2 more weeks thereafter before you move to the 100. But again, that's going to be our max at that point. If they're taking Tegretol, phenobarb, phenytonin, or primidone, other anti-epileptic medications, then you're going to have to start higher. So you actually, because those are going to induce it to pass, you can start 50 milligrams of Lamictal once a day for 2 weeks, then 100 milligrams divided into 2 doses for 2 weeks, and again, your max up to 400 per day after that. All right, Tegretol. So I started with the first 3, lithium, Depakote, Lamictal. Those are your big boys. Those are the ones you're going to see most often. Tegretol is still widely used in psychiatry, and it is still, if I guess we had to kind of look at, a lot of the times you see them most often, almost kind of going in sync as we continue to go throughout the lecture or the PowerPoint. You'll see that things we actually use less and less as far as mood stabilization, but Tegretol still has some research there. So obviously carbamazepine, also another anti-epileptic medication drug, okay? If there's a level again, right? 4 to 12, all right? Remember, please, 4 to 12, all right? Off-label, it's been used for bipolar depression, bipolar maintenance, and then again, adjunctive with psychosis schizophrenia patients. Its action or absorption is slow and unpredictable. That's always great to hear, unpredictable, okay? Food actually enhances absorption, so we do need to educate in this aspect patients to have food with our Tegretol so that we absorb it better, okay, and use it more freely. Peak plasma concentrations reached in 2 to 8 hours after a single dose, and a steady state reached within 2 to 4 days on a steady dose. Again, if we're outpatient, most of the time we're withdrawing within a week. If we're inpatient, within 3 days. Usually we can typically redraw that lab and see where we're at, okay? Half-life ranges from 18 to 24 with an average of 26. It is metabolized in the liver, therefore we're going to have to watch our liver enzymes. And again, activity of treatment for bipolar is unfortunately still unknown. We might have, and we've seen from research, but we still don't know exactly why or how it works. So, with Tegretol, some things you need to know. And again, you can refer back to your Kaplan and Sodict, and there is another table for drug interactions when it comes to Tegretol. But decreasing serum concentrations of numerous drugs because of that hepatic CYP3A4. There's that first pass effect. There's that because it's metabolized in the liver. We're having things that can be induced or inhibited due to the Tegretol or something inhibiting, inducing it as well. One of the big things you need to know, okay, is Tegretol, or carbamazepine, the generic, decreases blood concentrations of oral contraceptives, okay? So, if I've got a patient who is childbearing age, I need to be letting them know, okay, and they're sexually active, I need to let them know that their birth control may not work as effectively, okay? So, we may have a higher risk of getting pregnant, and if they're on those oral contraceptives for, maybe there is some premenstrual dysphoric issues or bleeding or hormone things, then we need to let them know that they may have some breakthrough bleeding or some of those similar symptoms on why they started the birth control in the first place, okay? Now, Tegretol also should not, like most drugs actually, should not be administered with MAOIs. Again, why you hear we very little use them any longer, because they seem to do this with a lot of things. But Tegretol specifically should not be administered with MAOIs, and they should be discontinued at least 2 weeks before starting Tegretol. And that is the same way as going from MAOI to another antidepressant. If used with Depakote, decrease the Tegretol dose, because Depakote actually can replace the binding on proteins, and the dosage of Depakote may need to be increased. Okay, so Tegretol dose, you do not have to have as high a Tegretol dose when used in combination with Depakote. Adverse effects of Tegretol can have blurred double vision. It can have, tummy upset, some vertigo. We do, like I said, we've got to watch liver, so the hepatic failure, possible pancreatitis. There is, although it's not as remembered as often is it compared to lamotrigine, but there's that Stevens-Johnson's risk, rash, okay, is still also a risk with Tegretol. The big boy, or the one that we associate a lot of times with Tegretol or carbamazepine, is the hematologic effects. There is the risk for agranulocytosis. In fact, actually aplastic anemia, where we're kind of a decrease on everything there, can be associated with Tegretol. So what are you going to want to check? Obviously, you're checking again. Here we go with that CBC, right? Because we want to look at our liver enzymes, you might want to draw it. A lot of times it's just getting a CDMP and then a Tegretol level. So the dosing, usually a target dose for anti-mania is 1,200 milligrams per day. For ages 13 and older, for bipolar disorder, you initially start 200 twice daily. And each week, you're going to increase by 200 milligrams per day in divided doses, with a max of 1,200 for adults and a max of 1,000 milligrams for children. Our maintenance dose is usually between 800 to 1,200 milligrams per day. Now, I included this one just so you guys have a little bit of, it's very poor mood stabilization effects with triliptyl. However, you may still see it, especially with your special needs population, because it is helpful in the in aggression and impulsivity. So you may see this with some of your ADHD kiddos, and as well with your special needs. So something to be aware of. Action of the triliptyl, structurally related to carbamazepine, peaks within 45 minutes Half-life is 2 hours. Side effects are sedation, nausea, most common. Does not have the increased risk of serious blood issues or hematologic. So that way, it doesn't have that risk factor for the aplastic anemia or granulocytosis as the Tegretol. So therefore, we're not having to usually be as mindful about that CBC. However, there is a risk of hyponatremia, so you do want to keep at least once yearly, keep a check on a BMP or basic metabolic profile, check on that sodium level, okay? Dosing is usually between 150 and 2,400 milligrams per day in divided doses of twice a day, typically between 900 to 1,200 milligrams per day with a starting dose of 150 to 300 milligrams at night. So again, I only included mainly just so that you might see it. The big thing is here is that we may use it with aggression impulsivity, add-ons, and watch that BMP for hyponatremia. Gabapentin or Neurontin you're going to see, and you probably see this a lot with pain management, and that's one of its indications. It's also gotten moved, unfortunately, to a controlled substance due to abuse, and so now it's one of those that we have to take extra precautions with, although it's been around for years and years and years for epilepsy. But used for epilepsy and pain management, off-label for psychiatry, we can use it as a hypnotic in once dosing at night, or an anxiolytic. And that is actually where you'll see more often in our field. And if you've got that person who's also suffering from pain management as well as anxiety, it might be a good option. Usually you're going to see in 2 to 3 times a day dosing. It can be helpful for social anxiety, panic disorder, and actually very beneficial and been shown to help decrease alcohol cravings. And so sometimes you'll see that a lot of times throughout rehab or on an outpatient basis to keep somebody from relapsing. Adverse effects, somnolence, ataxia, again, can make them fatigued, can be excreted through breast milk, and that fatigue should have been another parentheses on dose dependent to correspond with fatigue. Interactions, bioavailability may decrease as much as 20% when administered with antacids. So be aware, they need to spread out, okay, their use of their antacids, and usually that 2-hour ruling around the gabapentin and not be just taking them together. Dosing, generally, you start at 300 milligrams on day 1, then 600 milligrams per day 2, and up to 900 milligrams per day 3. Can increase subsequently to up to 1,800 milligrams per day, and usually can be seen as low as 200 to 300 milligrams per day. So Topamax, or topiramate, indicated for epilepsy and migraine prevention. Also, we use it for obesity treatment, binge eating, bulimia, and alcohol dependence. How does it work? Okay, let me start off to say this. Topiramate or Topamax, very, very little mood stabilizing capabilities again. Okay, very, very little therapeutic effect. However, you may still see it used. There is a belief that it has something to do with the GABA. There's some GABAergic effects and increases the GABA. Not affected by food, excreted by kidneys. Adverse effects though, we can have some weight loss, which that's why they use it for obesity treatment. Decrease of appetite with anorexia, memory problems possible. Now, here's something I want to mention. And just because it's specifically 2 patients in the last 6 months who were not started on Topamax by myself, but by primary care, had been on for other reasons due to migraine and for one of the patients, and then a male patient, it was a female, and then a male patient who the primary care was just trying something before they referred over to psych. Activation of suicidal ideations and behaviors, both. And when that was pulled, a magnificent difference in the depression already began to feel better. Now, were we there automatically? No. For that male, it was other things that we had to do to get him on a stable dose regimen. However, for that female, we had already thought we were getting to more stable and just coincidentally had stopped her medications and pulled herself off some of them and realized how much better she felt. But we also do have to be careful as an adverse effect for Topamax as well. It can affect our acid-base balance, so there is a possibility with cardiac arrhythmias and formulation of kidney stones. So we do need to encourage plenty of fluids if you're going to prescribe Topamax. The usual dosing is low as 50 to 300 milligrams per day. A lot of times you will see just like 50 to 100 added per day. And that's our dosing instructions say. You know, Stahl recommends 25 to 50 milligrams per day. increasing each week by 50 milligrams and administering again in 2 divided doses. But I will see a lot of times, especially if it's just at 50, especially for migraine prevention, once daily. So just an overview on our mood stabilizers. So lithium recommended for suicidal ideations, okay, decreasing the risk of suicide 13-fold with long-term maintenance therapy. Depakote is preferred for our rapid cyclers. There's been more research showing that Depakote is more of a stronger, hey, this can help and prevent these rapid cycling. Normal cycling can be anywhere from maybe like I said, once a year for bipolar, maybe twice. If you have 3 or more episodes in a year, you're considered more of a rapid cycler, okay? Hypomanic episodes and mild depressive episodes generally managed with a single mood stabilizer. You don't usually have to have more. Now, if you're in acute mania or severe depression, then we may have to have a combination with an atypical antipsychotic. We may have to have 2 mood stabilizers on board and a depressant mood stabilizer to kind of go from there. Now, use of antidepressants, and I haven't mentioned this yet, the use of antidepressants should be avoided or only used short-term, and I would actually just say, to be safe, avoided, okay, with bipolar type 1, okay? Antidepressant monotherapy can actually precipitate mania or induce a rapid cycling disorder between mania and depression. You will see antidepressants can be tolerated along with a mood stabilizer with bipolar type 2. However, bipolar type 1 contraindicated and can throw a person into mania. Okay, seeing this on the outside into the clinical world, I remember actually sitting with a patient who had come back in, and this was actually when I was precepting with a nurse practitioner who came in and was just saying how good she felt and how happy and smiling. And of course, my preceptor was like, "Oh, this is great news. This is wonderful. I'm so excited." And to see, turning to me and explaining how she'd been before. As the patient went into more detail, she revealed that she had painted her whole house in a weekend. So, and we, had to clarify. You painted a room? No, I painted my whole house. You did what? So when we actually go into detail, wait a minute here. Patient didn't sleep all weekend. She'd been up painting the house, each room, getting all the stuff she'd done forever. We may have messed up, or she had a reaction to the antidepressant and needed to be pulled back off. And that's exactly what happened. So just please, please, please be aware, okay, that it is possible you throw someone into a manic episode. It's also a lot of good times an identifier, asking patients what have their prior trials and what things they failed in the past, getting kind of the symptoms to find out, they keep having this reaction that's either made them a whole lot worse, okay, with antidepressants, so I might need to avoid those, and this is maybe I need to treat more on the bipolar means. Antidepressant drugs are also enhanced by mood stabilizer. So in the first line treatment, okay, or for bipolar depression, a combination drug can work. Combination, okay. There is a medication out there with olanzapine, which is Zyprexa, or fluoxetine, Prozac, called Symbiax. Now, I think it's more relatively affordable now, but there for a long while it was actually very expensive, and really you could get it just as cheap as getting the Zyprexa and the Prozac and just making your own combination, which you can do. But there is a drug if you have those patients who just don't want to take 2 pills, and just the thought of being on 2 medicines, you can do 1 medication. And Symbiax has been shown to be effective with bipolar depression within an 8-week period, just by not causing somebody to be in a mania or hypomania episode with a combination, because you've got the Zyprexa on board that's mood stabilizing and the Prozac that's helping with the serotonergic effects of the depression and anxiety. But again, more commonly used for your bipolar type 2, please avoid antidepressants with type 1. More overview, just preventing reoccurrences on moods. That's one of the things is it's just a challenge. Okay, finding that right balance. There's no absolute word, and I think you guys are learning throughout this course, I hope. And it's not that I don't have all the answers, and I try to actually give you extra tidbits along with the lectures. It's just that there's just not just one way of practicing. There's not just one right answer. There can be wrongs when we have contraindications and things that we're we are rightly aware about, but it is all patient subjective based, and what you see and how they respond. Again, everybody is different, so trying to maintain that, preventing them from being too euthymic at the same time that we're not also wanting to numb them or don't have any feelings at all, we want to keep a good level. If we cannot, you know, maybe we've gone through several trials of medications and we're trying to find that therapeutic level, ECT may be a great thing to help. So electroconvulsive therapy can actually be useful with patients with bipolar depression when they don't respond to lithium or mood stabilizers or their adjuncts. And especially when there's intense cases of suicidal tendencies, then having those medications, or excuse me, having ECT can be a good way of treatment for your patient. All right, that is the end of our bipolar lecture and mood stabilizers. I hope that you, again, had some clinical tidbits and learned some things from this lecture to take forth with you into practice and in your future careers. As always, if you need anything, please reach out and let me know, and put your questions or concerns in the discussion. And also make sure to participate with your peers' autobiographies this week so you can get a more comprehensive review also of your mood stabilizers. All right, hope you guys all have a wonderful week, and we will see you soon for our review coming up for our first safety exam. All right, thank you.